Good day, everyone. Today, I'll be discussing about anxiety disorders. Everyone gets nervous and everyone has fears. Everyone experiences anxiety in different times in their lives. It is characterized most commonly as a diffuse, unpleasant, vague sense of apprehension, often accompanied by autonomic symptoms such as headache, perspiration, palpitations, tightness in the chest, mild stomach discomfort, and restlessness. But what happens when anxiety takes over somebody's life or the DSM says that it causes significant impairment in functioning? That is anxiety disorder. Among the various mental health disorders, anxiety disorder is considered to be the most prevalent but the most treatable. Anxiety disorder is a very prevalent disorder, and this is not surprising considering that in our evolutionary history, the quick appraisal of threat has had persistent life or death importance. So here it is important for us to differentiate fear from anxiety. The experience of anxiety has two components: the awareness of the physiological sensations such as palpitations and sweating, and the awareness of being nervous or frightened. And both are alerting signals. Fear emotional response to real or perceived imminent threat, while anxiety is an anticipation of a future threat. Anxiety warns us of impending danger and enables a person to take measures to deal with the threat, while fear is a response to a known, external, definite, or non-conflictual threat. Anxiety is a response to a threat that is unknown, internal, vague, or conflictual. It has also been identified that anxiety develops from the perceived gap between one's estimated ability to cope with the challenge and the estimated difficulty of the task itself. So if the self perceives that he cannot cope with a particular challenge or demand, then that poses a threat to the self or to the system of the person. In this slide, we can see the comparison of identified disorders between the DSM-4-TR and the DSM-5. Okay? So, the separation anxiety disorder and selective mutism were formerly included in the chapter on other disorders of infancy, childhood, or adolescence. On the other hand, obsessive compulsive disorder and related disorders became another chapter in DSM-5. The post-traumatic stress disorder and the acute stress disorder became a chapter in DSM-5 entitled Trauma and Stressor-Related Disorders. So this table presents a rundown of the various types of anxiety disorder, including their corresponding triggers, as well as the frequency and severity of the symptoms per disorder, as well as the duration of the various symptoms for it to qualify in each particular anxiety disorder. So first in the list, we have separation anxiety disorder, and the primary trigger is the separation of the person from the attachment figure. Okay? Considering that this is an attachment to a primary caregiver, we have the notion that the disorder or the symptom has its early beginnings in childhood. Okay? Symptoms can be both intermittent and situational. And for it to qualify as a disorder, 3 out of the 8 symptoms should be present. And the symptoms should be already manifesting or visible before 18 years old. For children, the symptoms should last at least 4 weeks to qualify as a separation anxiety disorder, while for adults, symptoms should be manifesting for at least 6 months. So for selective mutism, the trigger here is difficulty in speaking in social situations. And it can happen both intermittent and situational. And the symptoms should be manifesting for at least a month. For agoraphobia, the trigger here is public transportation like open spaces, enclosed spaces, standing in line or being in a crowd, being outside of the home alone. So the symptoms can be both intermittent and situational, and the duration of the symptoms should be there for at least 6 months. For specific phobia, the phobia here is identified to a specific object, situation, or circumstance. Can be both intermittent or situational. And the symptoms should be there for at least 6 months. For social phobia, this is the one identified with Chris Evans. Can you imagine that? Mr. America. He used to have this, but he's able to manage and overcome it. So the trigger here is social situations exposed to possible situations. Okay? And the symptoms can be both intermittent and situational. Intermittent means on and off. Situational when the particular trigger is available or present. And the symptoms should at least be there for 6 months. For generalized anxiety disorder, there is a pervasive or excessive anxiety and worry about a number of events or activities. So for specific phobia, there's a particular object, situation, or circumstance. For GAD, or generalized anxiety disorder, is encompassing to a number of events or activities. So the symptoms are persistent and unvarying and should be there at least 6 months. For panic disorder, this is the occurrence of recurrent, unexpected panic attacks. And the symptoms should be intermittent and situational. And there should be at least 4 identified symptoms from the 13 identified diagnostic criteria for it to qualify as a panic disorder. So duration, the symptoms could be manifesting once per week for several months, frequent in weeks or months, or practically 2 months for a particular year. Alright. So earlier, I gave you the triggering factors and the appearance and the episode severity and frequency of symptoms as well as the duration. Here, we will talk more in depth about each particular disorder, but we will highlight now the major symptoms and the identified risk and prognostic factors. So for general anxiety disorder, it is described or characterized to be having persistent and excessive anxiety and worry about various domains. It occurs most days for at least 6 months. Anxiety and worry are associated with 3 or more symptoms, one for children. Okay? So, what are these symptoms? Restlessness, being easily fatigued, difficulty concentrating, being irritable, experiencing muscle tension, and sleep disturbance. So for the risk and prognostic factors, we have identified 3 in our list. It can be temperamental, okay, behavioral inhibition, negative affectivity, harm avoidance, reward dependence, and attentional bias to threat. Environmental risk factor can include childhood adversities and parenting practices. Okay. Genetic and physiological risk factors would include 1/3 of the risk is genetic and an overlap with neuroticism shared with other anxiety and mood disorders, particularly in major depressive disorder. And the worry is sustained for at least 3 months. For panic disorder, the major symptoms would include recurrent unexpected panic attacks with at least 4 out of the 13 physical and cognitive symptoms, persistent threat about future attacks, and at the same time, behavioral or maladaptive changes manifested by the person. So, what are the risk and prognostic factors for panic disorder? So, temperamental risk factors would include negative emotions, fear of anxiety symptoms, avoidance of new situations, and a tendency to avoid risks. Environmental risk factors, on the other hand, would include the presence of stressors in the environment, trauma, parental factors, economic resources, and smoking. Okay? Genetic and physiological risk factors would include uh, multiple genes, subnormality or aberrations in multiple genes, family history of anxiety disorders, respiratory sensitivity, and parental associations with or potential associations with asthma. And the symptoms or the panic attacks can last up to 20 minutes and usually peak within 10 minutes. Now we go for agoraphobia. So what are the major symptoms for agoraphobia? Okay, there is a marked fear or anxiety, especially in public transport, open spaces, enclosed spaces, standing in line or in crowds, and being outside alone. Okay, there's also fear or avoidance. Situations provoke fear or anxiety, and public spaces mentioned above are actively avoided. And fear and anxiety is out of proportion, persistent, which means it's there 6 months or more, and the exposure or the anxiety provoked is distressing or causing impairment to the person. And the worry is not better explained by other conditions as well. So what are the identified risk and prognostic factors? So temperamental, that includes behavioral inhibition and anxiety sensitivity. Environmental risk factors would include experiencing stressful or traumatic events, childhood experiences such as overprotective parenting or a history of separation anxiety. Genetic and physiological risk factors would include having a strong genetic component, increased risk if there is a family history of anxiety disorder. So it always be a risk factor if we have a family member manifesting a particular anxiety disorder, be it anxiety disorder or the other mental health disorders that we have talked so far in class. Gender is identified to be a risk factor. So females are more likely to develop agoraphobia compared to males. Okay, and the fear of open spaces or enclosed spaces or being alone is typically persistent and lasts for 6 months or more. Alright, what about specific phobia? So major symptoms would include marked fear or anxiety about a specific object or situation. The phobic object or situation almost always provokes fear or anxiety, and it is actively avoided or endured with intense fear. Okay? The fear anxiety is out of proportion to the actual danger. So it's exaggerated as we may describe it. It is persistent, so 6 months or more. It causes significant distress or impairment, and it is not better explained by other disorder. So what are the risk factors for specific phobia? So temperamental risk factors would include behavioral inhibition and high anxiety sensitivity. Environmental risk factors would include traumatic experiences involving the phobic object or situation, observing others going through traumatic experiences, and informational transmission. Okay, yung na-observe natin or yung disclosures from other people or vicarious experiences from other people, especially those who are significant to us. Genetic and physiological risk factors would include family history of anxiety or phobic disorders, and they are more likely to develop specific phobias. So gender risk factor, so females again are more likely to develop specific phobias than males. Okay? And symptoms is typically persistent with the fear, anxiety, or avoidance behaviors lasting for 6 months or more. For social anxiety disorder, major symptoms would include intense fear or anxiety in social situations where the person may be judged or scrutinized. Okay, there's a fear of negative evaluation. Situations are avoided or endured with intense fear. The fear is disproportionate to the actual threat. So again, it's exaggerated. It's more than the expected. The fear or avoidance is persistent, lasting for 6 months or more. And significant distress or impairment is observed in the person. And the disorder is not due to substance use, medical conditions, or better explained by another mental disorder. So risk factors for social anxiety disorder would include temperamental risk factors such as behavioral inhibition and fear of negative evaluation. Environmental risk factors would include childhood adversities and social trauma. Genetic and physiological risk factors would include family history of anxiety disorders and genetic predisposition to increased fear responses. So, gender is identified again as a risk factor. So, social anxiety disorder is commonly observed among females. And the symptoms for social anxiety disorder is typically persistent with the fear, anxiety, or avoidance behaviors lasting for 6 months or more. For separation anxiety disorder, the major symptoms would include developmentally inappropriate and excessive fear or anxiety of separation from attachment figures. So, the person is manifesting clinging behaviors and shadowing, following parents for children. So risk factors would include environmental factors such as social anxiety disorder developing after life stress, especially a loss, history of parental overprotection, and intrusiveness may be associated with both childhood and adulthood. Genetic and physiological factors would include heritability, where heritability was estimated at 75% in a community sample of 6-year-old twins, with higher rates found in girls. So again, the symptoms for SAD should last at least 4 weeks in children and adolescents, and typically 6 months or more in adults. So as you can observe, the duration of symptoms in adults are longer compared to children. And last but not the least, identified anxiety disorder is selective mutism. So the major symptoms would include persistent refusal to speak in specific social situations despite being able to speak in other contexts. It also includes situations wherein uh, the identified person is performance in education, job performance, or social communication. So it is encompassing in various situations. The condition lasts for at least a month, and the inability to speak is not due to language issues, and the condition is not caused by other mental health disorders. So risk factors from the temperamental category would include negative affectivity, behavioral inhibition, parental history, receptive language difficulties as well. Environmental risk factors would include parental social inhibition, overprotective or controlling parents. Because the child is not given enough opportunity to express himself or herself. Genetic and physiological risk factors would include shared genetic factors, auditory, efferent neural activity abnormalities. And the symptoms should last for at least a month to qualify as selective mutism disorder. So one of the famous and has good psychometric properties, and one of the most translated instrument and available online. So it is non-restrictive. We have the Depression Anxiety Stress Scale, or the DAS-21, developed by Lovey Bond and Lovey Bond. And it is one of the most translated scale. So we have a Filipino scale developed by Annalisa Santa Ana, and it is also translated in other major languages as well. So you can check them online. So this is a sample algorithm that can be used in the diagnosis of anxiety disorder. Okay? So the first, or the starting question would be, do you have spontaneous anxiety attacks that occur without warning? And if the answer is yes, the next question to be answered is, had an attack in the last month and feared you would have another and had at least 3 panic symptoms. So if the answer is yes, then that is a panic disorder. But if the answer is no, that will qualify as a limited symptom attacks. Going back to the original question, if your answer is you're not having spontaneous anxiety attacks that occur without warning, the next question to be answered is, do you avoid certain situations so you do not trigger an attack? And if the answer is yes, then that will qualify for agoraphobia. Okay? But if the answer is no, you don't avoid certain situations, the next question to be asked is, do you mainly avoid situations because you fear embarrassment or other people's opinion? If the answer is yes, then that will qualify as social phobia. Okay? But if you do not avoid social situations, then the next question to be asked is, do you fear just one thing or a few things very specifically? Okay? If the answer is yes, do you have anxiety only with these things? Then that is a specific phobia. Okay? But if the answer is no, do you perform any rituals such as washing, checking, or counting? Then the follow-up question should be, do you have invasive thoughts that are out of control, like harming someone close to you, disasters happening, or being contaminated? So if the answer is yes, that will qualify as OCD. Okay, but if no, that is OCD. Okay, but remember in DSM-5, OCD belongs to a different chapter already. Okay, do not forget that. But if you do not perform in your rituals such as washing, checking, or counting, the next uh, follow-up question is, do you worry excessively without any specific attacks or phobias? And if the answer is yes, the follow-up question should be, do you suffer from 3 or more of the following, like restlessness, fatigue, poor concentration, irritability, physical tension, and sleep problems? And if the answer is yes, that will qualify to be generalized anxiety disorder. But if not, that is a limited symptom anxiety. Did anxiety develop after a traumatic event? If that is yes, then that can qualify either as a PTSD or an ASD. Okay. So here, distinct symptoms on the different anxiety disorder is also depicted. So growing evidence that panic attacks without panic disorder are associated with increases in a wide range of psychopathology and impairment. So here you can see the major stressors or descriptions. So for GAD, consistent worry and physical symptoms. For OCD, although it's a different chapter already in DSM-5, excessive repetitive thoughts and behaviors. Social phobia, embarrassment, and humiliation in social situations. PTSD, in a different chapter already in DSM-5, thoughts and experiences of horrible event. And panic disorder is characterized to be having frequent spontaneous attacks plus avoidance of the triggering stimulus. So panic attack would include palpitations, sweating, trembling, shortness of breath, choking, chest pains, nausea, dizziness, unreality, fear of loss of control, fear of dying, paresthesias, hot or cold flashes as well. So anxiety is often a comorbid disorder with major depression disorder or depression disorders. Later on, you'll see that cognitive patterns for both depression and anxiety are somewhat similar. It may be difficult to separate anxiety from depression when both disorders occur, especially that they are usually comorbids. This is because the symptoms of one disorder might disguise the symptoms of the other disorder due to symptom overlap. So depressive disorders and anxiety disorders both include symptoms of psychomotor agitation, difficulties with concentration, and sleep disturbances. However, individuals with both anxiety and depression tend to have more severe and chronic depressive and anxious symptoms when compared to individuals with either disorder alone. Unfortunately, the increased severity of symptoms predicts a poorer response to threat and a larger negative impact on the quality of life. Anxiety and depression are suspected of sharing a genetic pathway. So, what are the common symptoms between AD and MDD? So, we have sleeping concerns, concentration issues, the experience of fatigue. What else? But the differential symptoms would include, for anxiety, it is anxiety and worry, so that's really very pervasive. For depression disorders, that is depressed mood and loss of interest and difficulty experiencing pleasure. So, the other distinguishing symptoms for MDD would include suicidality, problems with appetite and weight, and feelings of guilt or worthlessness. But for AD, that would include being irritable, experiences of muscle tension, compulsions, panic attacks, and phobic avoidance. And these are results of having excessive worry. So those are the physiological consequences. That's why those are the corresponding symptoms. All right. So when we try to explain etiology of any disorder, we always do it biopsychosocially. So there would always be the influence of biological factors as well as psychological factors. And of course, we could not neglect the role as well of environmental or social causes. So, although we may be born with a biologically determined heightened sensitivity to stress, this fact alone is insufficient to create an anxiety disorder. The psychological factors in the biopsychosocial model refer to our thoughts, beliefs, and perceptions about our experience, our environment, and ourselves. So these cognitive patterns affect our perceived sense of control over our environment. And these cognitive patterns also influence how we assess and interpret events in our environment as either threatening or non-threatening. According to Barlow, 2002, once the biological and psychological vulnerabilities are in place, an individual may then learn from their social environment, such as their family, to focus their anxiety on specific objects or situations in their environment. Thus, the social component of the model refers to environmental factors that may trigger, shape, and strengthen the biological and psychological vulnerabilities. So, environmental factors can include stressors that commonly affect everyone, such as the tragic events of 9/11. I hope you are familiar with 9/11. They can also be more individualized stressors that may not be experienced by everyone. These might include financial stress, loss of a loved one, or loss of a pet. So there are two response systems towards stress or threat. Okay, so when faced with stressor, the first response, and which is usually the shortcut response, is the amygdala triggers or activates the hypothalamus. And then the hypothalamus activates our sympathetic nervous system. And in turn, the sympathetic nervous system releases epinephrine and norepinephrine for quick response. Alright? The HPA axis is a bit slower, but they last longer. Okay? Cortisol are steroid hormones that act as epinephrine. So cortisol increases amount of calcium entering neurons that leads to more neurotransmitters leading to extra arousal. And cortisol also increases stored energy for use in threatening situations. So this particular slide will talk about the pathogenesis of anxiety. So pathogenesis means the origin and development of anxiety. Alright, so it all starts with predisposition. Okay, and predisposing or risk factors, as we have discussed in previous slides, would include belonging to the female gender. Okay, by virtue of gender, we have hormonal factors, we have lesser internal control, and the greater reporting rates compared to males. Genetic risk factors would include positive family history or family history of anxiety and other biological factors. So, predisposition to anxiety would cover imbalance and or abnormal functioning of norepinephrine, serotonin, dopamine, and gamma aminobutyric acid. Alright? Predisposition to anxiety triggers our hippocampus and cingulate gyrus, and they are responsible for abnormally processing threat. There could be perceived environmental threat, and the ability of hippocampus to normally integrate environmental stimuli is further compromised. Okay, when the hippocampus and cingulate gyrus or gyrus is able to process threat abnormally, it triggers our amygdala. Okay, and the amygdala maladaptively activates the fear response. Remember the two routes for activation: the first route, the longer route, and the HPA axis. Okay, from there, the activation of hypothalamus pituitary adrenal cortex axis, and the activation of autonomic nervous system and adrenal medulla. So these are the two axes. So the activation of HPA will release cortisol, and the activation of our autonomic nervous system and adrenal medulla will lead to the release of epinephrine. And this contributes to interacting with stress hormones in the body in various complicated mechanisms. And this would eventually result to anxiety disorders. So, described to be a maladaptive emotional state causing fear, worry, and excessive stress characterized by physiological arousal, unpleasant tension, and sense of foreboding or apprehension. Alright? So, on the right side of the slide, you can see the mood dysregulation and memory impairment characteristic or mechanism that happens during anxiety experience. And these two symptoms alone would identify the strong association between anxiety disorders and depression. Alright? So we are still on the biological etiology of anxiety disorder. We have Martin Seligman, who proposed the biological preparedness model, right? And this preparedness theory of phobia holds that humans are biologically prepared to learn to fear objects and situations that threaten the survival of the species throughout its evolutionary history. Okay? And this is the mechanism that explains for the response why we are responsible for the rapid acquisition, irrationality, selectivity, and high resistance to extinction, considered characteristics of phobias. Okay? So, we have an innate or inborn tendency to learn certain kinds of associations relatively easily. So, majority of phobias are about objects of natural importance, the survival of the species. What causes a species to be biologically prepared to learn some associations more easily than others? So it seems plausible that the members of each species have innate tendencies to learn associations that were important for their evolutionary ancestors, to learn in order to survive longer, and hence to reproduce more. So we easily learn to fear objects or situations that probably were dangerous for our evolutionary ancestors. So in psychology, preparedness is a concept developed to explain why certain associations are learned more readily than others. So for example, phobias related to survival such as snakes, spiders, and heights are much more common and much easier to induce in the laboratory than other kinds of fears. According to Seligman, this is a result of our evolutionary history. The theory states that organisms which learn to fear environmental threats faster had a survival and reproductive advantage. So consequently, the innate predisposition to fear these threats became an adaptive human trait. So it's not really that bad after all. Okay. Kasi it's more of an adaptive trait for human beings. Okay. What about the social framework on the etiology of anxiety disorders? So, social learning theory, according to Bandura, which is the principal founder of SLT, individuals learn new ways of thinking and or behaving by observing how other people think and behave. Okay? So, learning can take place without any direct experience. And this has important implications for the formation of anxiety disorders. So it helps to explain the many different ways that people experience anxiety. So for social phobia, people were taught directly or indirectly that it was extremely important to receive the approval of other people. For panic disorder, people may have learned at a young age that any unexplained bodily sensation signals dangerous or dire illness. So what about the psychological framework for the etiology of anxiety disorders? So of course we cannot miss the role of the psychodynamic perspective. So under this perspective, it says that anxiety is a signal that the ego is having a hard time mediating between the reality, id, and superego. Okay? And there is a psychic conflict between unconscious, sexual, or aggressive wishes and corresponding threats from the superego or external reality. Okay? And unresolved childhood issues manifest as emotional symptoms. Okay? So different anxiety disorders are the result of different defense mechanisms people used to cope. So therefore, the goal of therapy is to increase anxiety tolerance, that is the capacity to experience anxiety and use it as a signal to investigate the underlying conflict that has created it. So there are 4 types of anxiety identified by Freud. So I'll just go through them. So first is disintegration anxiety. Self will fragment because others are not responding with needed affirmation and validation. Persecutory anxiety, self is being invaded and annihilated by an outside malevolent force. Castration anxiety involves the child who fears losing the love or approval of a parent or loved object. And superego anxiety, guilt feelings about not being able to live up to the internalized standards of moral behavior derived from the parents. So another theory from the psychological etiology of anxiety disorder is the cognitive theory of anxiety by Beck and Ellis. And they identify the presence of 4 cognitive mechanisms that paves way for the development of anxiety disorder. So first is the presence of cognitive appraisals, so how we evaluate an event. Second is the presence of negative triad, so how do we view ourselves, others, and the future negatively. Cognitive beliefs about the event itself and one's ability to cope with and or tolerate negative events. And lastly, we have cognitive distortions, the overestimation of threat and the underestimation of one's ability to cope with threat. So remember when I discussed the first slide, I mentioned that the greater the gap between our estimation of threat and our estimated abilities, the greater the likelihood we will experience anxiety. So the relationship between a person's individual, unique beliefs about an event, and the responses to that event is central to rational emotive behavioral therapy, or REBT. This particular type of cognitive therapy was developed by Albert Ellis. According to Ellis, the specific stressors in a person's environment do not directly cause their emotional reactions or problematic behavior. Instead, unhealthy responses are the result of a person's unique beliefs. These beliefs include not only beliefs about the event itself, but also beliefs about one's ability to cope with and or tolerate negative events. So generally, our beliefs are usually not evaluated in terms of their objective validity. The common expression, "you're entitled to your beliefs," reflects this acceptance. However, some beliefs can lead to distorted thoughts. These thoughts in turn may lead to distressing emotions and maladaptive behavior. So according to Beck and Emery, people are prone to make certain types of cognitive errors in their appraisals across various situations in their lives. So this is particularly true for people with anxiety disorders. These thinking errors are often called cognitive distortions. So taken together, our beliefs affect the way we experience and respond to a potentially threatening situation. So in general, the greater the gap between our estimation of threat and our estimated abilities, the greater the likelihood we will experience anxiety. Because these beliefs have such a powerful influence, interestingly, in clinical practice, we often see individuals who, despite their initial belief about their inability to cope with the situation, are often quite good at problem-solving solutions to threatening situations. So, for the goal of therapy under the cognitive theory is that it seeks to create an awareness of these cognitions and to challenge their accuracy. So, when these negative cognitions are challenged, and hopefully they will be eliminated, then that will uh, cure or treat the existence of the anxiety disorder as well. All right. So this is the negative triad associated with anxiety. So the negative views about the self, such as the statement, I'm unable to protect myself, negative view about the future, it's a matter of time before I get embarrassed, and the negative view about other people, people will humiliate me. So these negative triad are common among people who manifests anxiety disorder. And it always comes together with the existence of beliefs and distortions. All right. Another psychological theory for the etiology of anxiety disorder is the behavioral theory. I'm pretty sure you're very aware of the concept of classical conditioning, wherein there's the pairing of anxiety symptoms with the neutral stimulus in the context of anxiety. So because of this pairing, the neutral stimulus, which was previously considered non-threatening, subsequently becomes capable of automatically causing a fearful response. So, as I said earlier, anxiety can be learned through a type of learning called classical conditioning. So, this occurs via a process called paired association. So, paired association refers to the pairing of anxiety symptoms with a neutral stimulus. A neutral stimulus can be any situation, event, or object that does not ordinarily elicit a fearful response. So, in the previous example, the grocery store would be a neutral stimulus. By pairing the anxiety symptoms of an acute panic attack with the neutral stimulus, the grocery store, anxiety now becomes associated with the neutral stimulus. Thus, a previously neutral stimulus, the grocery store, now becomes or now evokes an anxious response. Because of this pairing, the neutral stimulus, which was previously considered non-threatening, subsequently becomes capable of automatically causing a fearful response. This is because the person has learned it was accused to do a threat. So the person has learned to be anxious via classical conditioning. Once this learning has occurred, the previously neutral stimulus, the grocery store, becomes a conditioned stimulus that spontaneously evokes a fear response. The grocery store now prompts acute panic attack due to the learning that took place. So in other words, the grocery store now serves as a cue for danger. Another is the presence of maladaptive coping strategies. All right. So, for example, one type of coping strategy is called sensitization. A person using this type of coping strategy seeks to learn about, rehearse, and or anticipate fearful events. This serves as a protective effort to prevent these events from occurring in the first place. So these efforts result in hypervigilance and obsessive worrying. So this type of coping strategy is commonly observed in people with generalized anxiety disorder. Okay? Children with separation anxiety disorder worry about the well-being of their attachment figure or worry that something may happen to keep them from being reunited, such as getting lost. Another type of coping strategy is the use of safety behaviors. So this refers to coping strategies where people come to rely on something or someone as a means of coping with their excessive anxiety. So this may be demonstrated by an exuberant amount of time and energy seeking reassurances of safety or repeated reassurances that some disastrous consequences will not befall them. Examples of common safety behaviors include shopping only when accompanied by someone else, carrying around medication just in case, refusing to drive unless someone talks with them on the cell phone while driving. Ironically, this is hardly a safe behavior. In addition, people with panic disorder often refuse to go certain places without being in the presence of their safety person. Likewise, children with separation anxiety may refuse to go to school or go to bed for fear of being separated from their attachment figure. So now we realize that our anxiety tendencies or behaviors are ways of coping, though they are maladaptive. Okay. In addition, in the maladaptive coping strategies, we also have anxious avoidance and escape. So, but by far, I think the most common coping strategy is called anxious avoidance. So, this coping strategy refers to the avoidance of anxiety provoking situations. Unfortunately, if a person does not confront the feared situation and instead avoids it, their fear will mostly likely be maintained. An avoidance coping strategy serves to maintain anxiety disorders because the person never has the opportunity to learn that they can tolerate their anxiety. Likewise, they cannot have new experiences that would allow them unlearn the faulty beliefs they have come to associate with the situation. Unfortunately, the strategy of avoidance is successful in the sense it temporarily takes away the unpleasant experience of anxiety. Through a learning process called operant conditioning, the person learns to avoid the negative experience of anxiety. So, according to the principles of operant conditioning, a behavior that serves to remove an unpleasant consequence, in this case, the reduction or elimination of anxiety symptoms, will cause that behavior to increase. In other words, the reduction in symptoms will cause avoidance to occur again. This is called negative reinforcement. Negative reinforcement means the removal of something, negative reinforcement, that causes an increase in a behavior. Reinforcement. To make matters worse, avoidance eliminates opportunities to learn how to tolerate, to master, or to overcome the fear-producing situation. Let's use an example to illustrate the powerful effect of negative reinforcement. Suppose Maria, who has social phobia, receives an invitation to a party. The moment she receives the invitation, Maria will begin to feel anxious and worry about the party. Next, she may begin to think, nobody will like me. I'll probably do something embarrassing. These thoughts and feelings are highly unpleasant and uncomfortable. However, if she decides to avoid the party by not attending, her anxiety level will immediately decrease. This is because she has eliminated the threat, which is the party, by deciding not to go. Since her anxiety decreased by avoiding the anxiety-provoking situation, her coping strategy avoidance is negatively reinforced by the removal of these bad feelings. She has now learned that avoidance is a highly effective coping strategy that eliminates the unpleasant feelings of anxiety. Therefore, the next time Maria confronts a similar anxiety-provoking situation, she is quite likely to use the same method that worked so well before, like avoidance. Although in the short term, this strategy may reduce her anxiety, in the long term, it only interferes with her ability to overcome her fear. Avoidance behaviors deprive individuals of the opportunity to learn that their fears are unwarranted, or at very least, that they are capable of effectively coping with the situation. The result of this maladaptive coping strategy is Maria will remain socially isolated and unable to enjoy the many rewards of social relationships. While the principles of operant conditioning can serve to maintain an anxiety disorder, these same principles form the basis for some very effective treatments. A strategy similar to avoidance is one of escape. This strategy is often used by people with panic attacks and phobias. Likewise, selective mutism can be considered a child's version of escape. More specifically, when we encounter an anxiety-producing situation, our attention begins to shift. We become overly focused on the signs of threat. This narrowing of attention causes our subjective feelings of anxiety to rise. Our desire to escape the situation increases. However, if we do not remain in the panic-producing situation long enough, we can never discover that anxiety will naturally subside on its own. Alright? So moving forward, we're already on the treatment and interventions for anxiety disorders. So cognitive behavioral therapy is considered as the gold standard, um, and it differs from earlier therapies. Okay? Its primary focus is the present or the here and now rather than on the past. It assumes that people in the recovery can make progress without having to unearth the past in order to determine the origins of their symptoms. Instead, progress occurs by recognizing, understanding, and changing dysfunctional thoughts, emotions, and behaviors. It is assumed and accepted that these dysfunctional patterns have been learned and reinforced during prior life experiences. Nonetheless, the patterns can be unlearned in the present by creating new experiences. Simply stated, CBT is based on the premise that people's dysfunctional thinking and behavioral patterns contribute to the development and maintenance of an array of difficulties. So these difficulties range from daily stress to full-blown psychological disorders. Consequently, the main goal of CBT is to help individuals change problematic beliefs and thinking patterns while learning to engage in more adaptive behaviors. These changes relieve a person's symptoms and to restore their quality of life. In a sense, by treating the symptoms in the present, the therapist and therapy participant are chipping away at the psychological vulnerability that was formed in the past. Okay? So the goal of therapy is to help individuals change problematic beliefs and thinking patterns while learning to engage in more adaptive behaviors. Alright? Another is the exposure therapy, often called as the habituation. So, exposure therapy may be conducted using in vivo exposure, meaning real-life exposure to the feared stimulus. It can also be conducted using imagination or both. The use of imagination is particularly useful in cases of trauma or other occasions when in vivo exposure is not practical. So once habituation occurs, the fearful behavior will eventually be extinguished. So another intervention is systematic desensitization. So wherein a person is taught to relax, after which gradually exposed to progressively more intense experiences of the situations that they fear. Another is acceptance and commitment therapy. So the overall message of acceptance and commitment therapy is that the meaning and importance we assign to our thoughts perpetuates our emotional suffering. While ACT is very similar to traditional cognitive behavioral therapy, it differs in that it accepts and embraces dysfunctional thoughts. So instead of attempting to challenge and correct dysfunctional thoughts as would conventional CBT does, therapy participants are encouraged to view these thoughts dispassionately. So instead of attempting to challenge and correct the dysfunctional thought, everyone thinks I'm ugly, the person detaches from the meaning of the thought. So this would become, I'm simply having a thought that everyone thinks I'm ugly. Another intervention is the dialectical behavior therapy or DBT, proposed by Marshall Lineman, who is known to use this method in curing highly suicidal female with borderline personality disorder. So dialectical behavior therapy may be beneficial for persons who are reluctant to engage in exposure and response prevention therapy or ERP. However, it integrates an Eastern philosophical approach of acceptance and mindfulness meditation. Dr. Linehan found that the heavy emphasis on change inherent in cognitive behavioral methods was problematic for many therapy participants. So for these people, this emphasis on change invalidated their experience and discounted their suffering. So the term dialectic refers to the synthesis of two opposing facts or ideas. Thus, in DBT, the dialectic is between change and acceptance. So in this framework, we examine and discuss opposing ideas in order to find the truth, and the therapists in the sessions explore contradictory emotions, cognitions, and behavior. So in one way, we're not invalidating the experience and suffering of our clients. So the goal in therapy is to help therapy participants find the balance between these two contradictory ideas. And in therapy, acceptance and validation of client and expectation that client will change. So these are the DBT skills at a glance. So DBT uses a combination of individual therapy along with structured skills training groups. So participants are taught skills that enable them to better regulate their intense emotions. Second, become more effective in their interpersonal relationships. And third, improve their ability to cope with emotional crises. And fourth, decrease their reliance on unhealthy coping behaviors such as substance abuse, self-injury, and suicidal behaviors. So dialectical behavior therapy may be beneficial for persons who are reluctant to engage in exposure and response prevention therapy. All right. So looking closely, these are the various skills that are being taught to our clients during DBT sessions to increase their interpersonal effectiveness, to regulate more their emotions, and to increase their tolerance towards stress. Okay. So, what are the psychoeducational skills? Mindfulness improves control of attention and mind. All right. So, it is achieving a balance between our rational mind and our emotional mind. Okay. Wherein we come about an intuitive way of thinking. There's a balance between the elements of our rational mind and emotional mind. Okay. And living mindfully as the core component of mindfulness. Living mindfully means focusing on the moment without judgment. All right. So these are the interpersonal skills and conflict management under DBT. And emotion regulation as the third component of the DBT. So achieving more healthy perspectives about emotion. Okay. You are already third year psych students. We know that emotions are neither good or bad. Okay. So they are data that tells us something about what's going on. But they are not facts, and we cannot get rid of our emotions because it's a part of our survival. And we also know that emotions don't last forever. And the fourth component of the dialectical behavioral therapy is increasing our distress tolerance. So skills for tolerating painful events and emotions. We cannot make things better right away. So aside from the previously mentioned treatment and intervention frameworks, we also have identified some complementary therapies that we can add to our frameworks as we seemed that they are helpful in the process. So first is meditation. Meditation practice encourages the improved coordination of limbic and cortical functions that can also be produced by successful psychotherapy. By focusing to the breath and getting some distance from the compelling qualities of the anxious mind state, mindfulness and other body-oriented relaxation practices can help patients develop better prefrontal control over an overactivated amygdala. Mindfulness means focusing one's awareness on the present moment while calmly acknowledging and accepting one's feelings, thoughts, and bodily sensations. So we can make use of meditation as an addition to the interventions that we have identified earlier, but not with DBT already, because mindfulness or meditation is a part of the dialectical behavioral therapy. So we can add meditation with CBT and the other therapies that we have previously mentioned. Second complementary technique is hypnosis. So as a suggestion therapy, the hypnotic state makes the person better able to respond to suggestions. Hypnotherapy can help people change perceptions and sensations. All right. Third complementary therapy that we have identified is progressive muscle relaxation. So progressive muscle relaxation involves tensing and then relaxing different muscles in the body. This exercise helps a person learn how to relax when he or she is feeling anxious or stressed. Okay, for me personally, when I feel so tired or when I feel some tension in my muscles already, I do PMR. Okay. Additional complementary therapy is in the form of exercise, yoga, and breathing exercises. Alright, so this table will show us what are the recommended techniques for each particular disorder and what has been found to be working or evidence-based as identified by Hunsley, Elliott, and Theory in 2014. So for generalized anxiety disorder, the recommended techniques involves CBT, supportive therapy, insight therapy, and psychopharmacology. But what has been found to be working and resulting positive results will be CBT first and then followed by pharmacotherapy. When we say pharmacotherapy, there is the use of medications. So for a specific phobia, what are the recommended techniques? So we have behavioral therapy, insight-oriented techniques, hypnosis, supportive therapy, family therapy, psychopharmacology, and in vivo exposure. So when we say in vivo exposure, it refers to the direct confrontation of feared objects, activities, or situations by a patient. Alright? And for specific phobia, what has been identified to be delivering positive results would be the exposure-based CBT. For social phobia, the identified recommended techniques would include behavioral, systematic desensitization, psychopharmacology, hypnosis, muscle relaxation, flooding, family therapy, progressive muscle relaxation, and habituation. But what has been found to be working will be the use of SSRIs and cognitive behavioral therapy. For panic disorder, on the other hand, the recommended techniques would include psychopharmacotherapy, CBT, relation techniques, in vivo exposure, insight-oriented psychotherapy. And what has been found to be working in order will be first, combined relaxation and exposure therapy, second, exposure therapy and cognitive therapy, third, exposure therapy, fourth, relaxation, fifth, a combination between exposure, cognitive therapy, and relaxation. Alright? For OCD, although OCD is not a part on the chapter of anxiety disorder anymore under the DSM-5, but OCD Recommended techniques would include psychopharmacology, psychotherapy, and a combination of the two. And what has been found to be evidence-based is the use of CBT with exposure and response prevention. So this would end our discussion on anxiety disorders, and I hope you have a better understanding on the etiology as well as the major categories or classifications of anxiety disorder. At the same time, the recommended techniques on how to deal with the various kinds or classifications of anxiety disorder. Thank you for watching.